Hi, everyone, and thank you very much for joining us today in this
Hello.
Hi, Mirna. This is the second virtual dialogue on breast cancer. You are all welcome, and I'm inviting you to please put your microphone off so that we don't have any background noise. Thank you. You are free to introduce yourself in the chat box, introducing your name, organization, and country. For those who don't know me, my name is Sabrina Zucchello, and I coordinate the breast cancer activities at UICC, including the new breast cancer program that we have launched earlier this month. This is an additional effort to tackle the #1 cancer in women worldwide. The breast cancer program aims to reduce the expected premature death from breast cancer by 2025 by strengthening and engaging the global breast cancer community. And to achieve this goal, UICC is bringing a focus on breast cancer across our capacity building activities and portfolio, as well as across our convening platforms. This is to offer our members a comprehensive set of opportunities, including online learning and best practice sharing program, a mentoring of patient groups, fellowships, and special focus dialogues as we are doing today, just to mention a few of these opportunities. And this program is supported by Pfizer, which is our founder partner, Daiichi Sankyo, the NCI Center for Global Health, and the Breast Health Global Initiative. So in today's topic, we are going to talk about early cancer detection and why it matters so much. We are also going to talk about how breast cancer early detection and management can become a model for other cancers. And for this talk, we are honored to have two renowned experts in this field with us today. This is Andre Ilbawi, Technical Officer at WHO in the NCDI unit, and Benjamin Anderson, the Director of the Breast Health Global Initiative, who is also working as a consultant for WHO. So a warm welcome to both of you, and thank you for being with us today. We're going to get started for our first presentation with Andre Ilbawi. And after the presentation, we'll have a short time for Q&A. So please prepare your questions for him. You can either use the chat box to post them, or just keep them in your mind for when the presentation will be over. Thank you, and Andre, it's over to you.
Good morning, good afternoon, colleagues. Thank you, Sabrina. Thank you to UICC for the invitation to take part in this very important discussion. As Ben and I were reflecting on this concept of early diagnosis and screening, it is perhaps one of the most common questions we receive from governments when we work with them on setting policies and program priorities in cancer prevention and control. Should we screen? What cancer should we screen for? What age, what modalities, and is screening appropriate? It's quite a tall order for us to tackle this complex task in an hour, and we very much look forward to hearing the real world perspectives that each of you bring to the table. So what we'll do is break it into two parts. From the first portion, I'll focus on what are the key principles as we think about early diagnosis versus screening. What is this concept of phased implementation, and how is it relevant to the broader cancer agenda? Ben will then take it on and make it very applicable to breast cancer, which is what we know is a priority bringing each of us here today. So just as a starting point, perhaps we should focus on this question of why does early detection matter? If we can imagine, and this is, as we know, quite common, the average country with 10,000 women who have breast cancer per year. We know from some death records that about 6,000 die. So the government comes and says, well, what should we do? Should we invest in high technology? Should we improve our access to medicines? Should we deal with workforce issues? And where does early detection fit? Here's a common portfolio for the country: late diagnosis, minimal infrastructure, and of course, some of the challenges with treatment availability. So if we start and just say, well, let's focus on medicines, technologies, radiotherapy. From that 6,000 women, we can estimate that about 500 will be saved, 500 more will be saved if we invest in building up radiotherapy or offering trastuzumab or other health products. And that, of course, is incredibly important. But just to give a sense of scale, if we just assume we can help downstage from 50% stage 3 and stage 4 to about 65% stage 1 and stage 2, we in fact can save more women and save money doing it as well. So this concept of early detection really is at the foundation of effective cancer control programs. But as we can imagine, the starting point is a challenge, and how do we achieve success is also not simple. If we were to map out what is the median stage of diagnosis across the world, and this is data from Dario Trapani that Ben and the group are starting to put together, we can see that for most countries around the world, in fact, late stage disease is common when survival rates or survival probabilities are lower. So what is it fundamentally that we need to do as a community to increase the number of early stage cancer diagnoses? There are two distinct strategies, and this is something that we will reiterate, and our also appreciation to UICC for making it very clear from the beginning in the title that early diagnosis and screening are fundamentally two very different ways of achieving early detection. They're marked by a very distinct moment in time, and that's when symptoms develop. Now, of course, symptoms, when they develop, it's not an exact moment, but it is quite distinct in how the health system responds. On the early diagnosis side, we know that if there is a symptom, we're talking about people who, for the most part, are limited to those who may have cancer at a much higher rate than those if we were to screen a general population. Because what we're doing is finding people who have symptoms, or they immediately present to the health system and begin the patient pathway from diagnosis to treatment. The entire system is oriented around making sure that those individuals who have high-risk symptoms get the diagnosis and treatment as quickly as possible. But it's very different with screening. When we talk about screening, it's the opposite. We don't know who in fact has cancer by just looking at them. So we use a test, some form of a screening test to see do they or do they not have a suggestion of cancer. The challenge, of course, is the test isn't always perfect, which is why you can see that this group of people here on the screen are great. Because we don't know even after administering the test whether or not that cohort will have cancer. It requires a much more complex system to respond to the needs of people who are being screened and screened positive when we compare those who present with symptoms. Now, let's look at it in a different way. First and foremost, screening. It's important when we talk about screening that we don't just limit it to the concept of mammography, colonoscopy, but recognize that it is in fact a process. It is more than just a test. So the test is important, making sure that the technology is available and high quality. But we have to think about the entire pathway, because without that pathway, the test itself won't have an impact. How do we get people sensitized to a screening program, encourage participation? How do we facilitate accurate diagnosis and staging? How do we make sure that treatment is available? And of course, that completion or receipt of treatment is done without financial hardship. And similarly, when we talk about early diagnosis, when we talk about people who have symptoms, it's more than just saying, we should just give an emphasis on awareness, because awareness will only get us so far, as we'll talk about later. In fact, there's an entire pathway for early diagnosis as well that we can't ignore. Yes, awareness, but what happens downstream? Ensuring there's an accurate diagnosis, the same pathway as above. So already in this slide, you can see that early diagnosis serves as the foundation for cancer screening programs. So what we'll focus on for the next 10-15 minutes are these decision-making points. First, when do we know if a program is ready for early diagnosis and or screening? And the first question is actually quite straightforward. In fact, every country around the world, regardless if they have a screening program, is always looking to improve early diagnosis. We've seen good experience from high-income country partners like Cancer Research UK that have implemented effective early diagnosis pathways and in fact have made a major difference. So the portion, is early diagnosis relevant? Yes, it is. It's relevant for all of us. But how about screening? We'll take a deeper dive into that. And then the second is, how do we start looking at some of the variables that help us understand, well, in my context, is screening appropriate? What types of programs should we be considering? And that's where we'll finish up this portion of the talk. Going into this, I'd like to also acknowledge a fellow WHO staff, our former coordinator, Dr. Cherian Varghese. He uses the term emotional epidemiology. This is really one of the most difficult conversations that we have in country with ministries of health, with civil society, and with others, because we all want screening to be effective. Screening does have the promise of reducing mortality, but that promise isn't always realized. So the question becomes, how can we analyze that specific context, remove any background biases, and focus on the science to inform the decision-making. Because of course, if screening can reduce breast cancer deaths further or cancer deaths further, then it's understandable that all populations would want it. But is it the right answer? So let's get into that question of readiness. When we think about the pathway, as Ben will also reiterate, early diagnosis and screening should be seen as a continuum. That governments start with early diagnosis, make sure that the infrastructure is in place, and make sure that the pathways are also developed so that any abnormality can get to treatment without any delay or loss to follow-up. And then after that, as we'll talk later on, what's the appropriateness of a pilot study? How do we achieve this population-based organized program that we all seek to achieve? As a point of reference, here is a country example with whom we worked just last year. As it pertains to how WHO approaches policy dialogues, we start with data. Can we all agree what the problem is? We engage in a dialogue. What are the responses that could be considered? And then ultimately making a decision with the stakeholder or the government itself. So the situation in this country, more than 50% presented with stage 3 or stage 4 disease. We said, okay, here are your options. Early diagnosis will in fact save lives. Early detection as a broad principle. But what's appropriate in your country? Early diagnosis for this country of about 5 million people. You can see you can deliver an early diagnosis program for $250,000 per year. Infrastructure is more or less there, and you can save 200 to 400 lives per year. Then we said, what about screening? The government said, we're very interested in breast cancer screening. So we ran it through a tool that WHO and IARC have now developed. And we say, okay, it's going to cost somewhere between $1 to $2 million, but you also have to think about the infrastructure. You have 5 mammograms, you're going to need 50, you have 3 mammograms, you're going to need 50 if you want to achieve 100% participation and coverage. You have some radiologists, you're going to need to train 3 more. And that changes the narrative because of course screening can be more compelling, but the thought of purchasing 47 more mammography machines is quite daunting for a country. So given that context, they said, okay, this is understandable. Let's start with early diagnosis. Cervical cancer is a slightly different decision-making algorithm. So we'll start with cervical cancer screening, early diagnosis, build in that pathway, and work our way towards a breast cancer screening program. Another point of reference to show again that these 3 radiologists are not insignificant. If we run the same exercise in other countries and say this is how many radiologists are needed for every 10,000 women screened between the age of 40 and above, so that's 10 radiologists per million population. Is that a high number? Well, in fact, for the countries in which we have some data on the screen left, you can see for the majority of countries, in fact, that number of radiologists exceeds the total number of radiologists in the country. So asking the question, do we have the workforce, do we have the infrastructure to deliver, is important as we look at that checklist from early diagnosis to screening. So how do we achieve early diagnosis? And this really is the emphasis that Ben will also highlight. This is a pathway. How do we get from this 90-90 target, as we heard in the HIV community, and apply it for cancer? So at least 80% aware of symptoms, and these percentages are just old estimates from WHO. But the goal is really to have everyone aware of cancer symptoms, everyone receive a timely diagnosis, everyone be able to access treatment in a timely way. When we look at the data, unfortunately, the minority are achieving any target, and because of it, millions of lives are being lost. The presumption is, and what we did to get a better understanding, is that the reason for delays in diagnosis is because people just don't show up. So we put a lot of responsibility on the patient, when in reality, as we found in the study, is that in fact, all phases are equal. So it's not just about getting the patient to the primary care clinic in time. It's about having diagnostic capacity and availability. It's about making sure they can get to the cancer treatment center in a timely way. Because in reality, all of those steps are equally important, and now we have the data to prove it. So this is not just a blame game, and I know I'm preaching to the choir here. This is a group of people that are very passionate about breast cancer. But it's important also to ask the government, please do your part. We can sensitize the community about breast cancer awareness, but you're going to have to help us get the diagnosis and ensure that they can access treatment, because those are also contributing to the delays. In this report from 3 years ago, we presented some of the options or interventions that governments can consider. And the key here again is to recognize that it requires a comprehensive approach. So just doing awareness won't be enough. It really does require interventions across those 3 steps. When we look at high-income countries, we know that the majority of women will present to their primary care providers with symptoms. In most high-income settings, they will have only 1 visit. Data from the UK, as we referenced, 72% of women had just 1 visit with a breast complaint, and that compares to 3, 4, 5, 6, or even more presentations in low and middle income countries. And this is some data that Ben will go And one more proof of encouragement. When we look at what has been achieved in high-income countries, this is a trend in the mortality incidence ratio, which is a surrogate, although not a great, but a surrogate for how many women are dying from breast cancer and the survival estimates that can be associated with them. You can see the extent to which achievement was reached in the first 25 years from 1950 to 1975 before screening mammography even entered the conversation. Awareness, confidence in the system, access to care, and high quality services, those are the bedrock of effective breast cancer control. So I'll go through these quickly because I think it's quite important we leave enough time for Ben and for discussions. But where are we as we get to the point of cancer screening? Because the challenge here is, in fact, most governments have made a decision to screen. And with that decision, we have some complexities. Screening is often prioritized over early diagnosis. Most of the countries that are doing screening programs are selecting the wrong patient population, as we'll show. Pilot studies aren't being done, and there's no budget being allocated to it. So women who are receiving screening tests are ultimately subject to either paying for the test itself or more concerningly for the follow-up. And the challenge now is because when we say to a country, focus on early diagnosis, the question becomes, what do we do with our screening program? And this is the context in which we're having these discussions. But we do have guidance from WHO, and as Ben will highlight, there's very clear guidance from other key stakeholders, including from the Breast Health Global Initiative. It's quite clear that for countries that don't have the infrastructure or health systems, mammographic screening is not cost effective and not feasible. So why is it that governments still do it? And this is one of the quotes from the Wilson and Younger criteria from 50 years ago. This was a landmark publication for WHO as to describe what is screening. They said back then, the central idea of early disease detection and treatment is essentially simple. However, the path to its successful achievement is far from simple, though sometimes it may appear deceptively easy. When we decide what screening program should be prioritized, there is consideration for the health system, and there's also consideration for what screening programs. Because when we talk about screening overall, lung cancer is distinct from breast cancer, which is distinct from cervical cancer. WHO, as part of its elimination strategy, has highlighted that all countries around the world can and should focus on cervical cancer screening, but that's quite different as we talk about breast cancer screening. And what are some of the challenges that we often see when countries now conceptualize cancer screening? As mentioned, they have no demonstration studies, they screen the wrong populations, they screen but don't offer treatment, there's no quality assurance program, no strategy for recruitment, call or recall, and we are unable to achieve the target, which is a population-based organized screening program. Here's some data to reinforce that. When we look at the question of what countries are offering breast cancer screening, you can see, in fact, that there are low-income countries that are offering screening. About half of low-income countries offer screening. When we ask those countries that are offering breast cancer screening specifically, do you offer treatment? 77% of them said no. So here we really have a fundamental problem. Screening is being offered. Often it's not organized or done under government oversight, but women are being screened. And there are many personal stories I think all of us can relate about the potential harms of screening. And of course, to add to the complexity, the lack of treatment that's available, lack of diagnosis and treatment available to those women who undergo screening tests. And we can see that this is particularly pronounced in the Afro region. As it pertains to age, I don't want to go into too many details here, but of course, screening a younger age population is also very risky. And why? It increases the number of false positives, it decreases the benefit of the screening program, and it significantly increases the overall cost. And when we ask governments, who are you screening? In fact, the countries that are screening the youngest women are also those from the lowest or middle income level. Why they screen? This is definitely a discussion that we're happy to have. Why do they screen younger women? It's often based on the misperception that people get cancer at a younger age. It is true that younger age at a mean age of diagnosis is the reality for low and middle income countries, but the statistical probability of developing breast cancer at a younger age is in fact higher in high income countries. And that is what should inform the starting age for a cancer screening program. And then finally, a brief comment on quality assurance, because in fact, the lower infrastructure for monitoring and evaluation, the greater potential harm, and also, of course, the very personal consequences on women and their families. When we talk about screening, just a high point here to reflect on, at least 10 to 20% of the budget should be allocated for monitoring and evaluation and quality assurance. And that is a high number to ask governments to invest in, but we know the benefits of doing so. So as we close, back to this concept of phase and implementation, as the organizers, as UICC highlighted. The first step, do we have adequate early diagnosis capacity? The second step, let's do a demonstration. Now, the demonstration is not to prove that it's cost effective. It is to prove that it is feasible, that it is equitable, and that it can be achieved as part of the broader cancer control strategy. So a pilot study has that important value. And then from there, looking how we can scale up and maximize participation rates. 2 slides for conclusions. The first, successful early diagnosis is in fact difficult. There's not an easy way to get people with cancer to present early, but it is necessary and it is the highest priority in the cancer agenda. And it does require interventions along the patient care pathway. Second, early diagnosis is the foundation of early detection, and screening programs cannot function well without adequate systems for early diagnosis. Third, screening can cause real harm to individuals and to the health systems, and that concept of the trade-off between benefits and harms is important not just for governments to make, but for stakeholders in the community to inform as well. And then finally, what is it that we can all do? This is just a word of appreciation. I was working in a rural hospital in Kenya. There was a young woman who came in with breast cancer, and they gave her this book that you can see on the screen right. This was a booklet that was developed by the American Cancer Society in coordination with the Kenyan government and other stakeholders. And it was remarkable to me as I was working in this hospital in Western Kenya, that this was the reference material that they were given. It was humbling, it was inspiring, and it's a word of encouragement that your advocacy does go a long way. So we all have an important role in advocacy, but doing so for evidence-based programs. Professional societies, we can all focus on what evidence can we use to inform policies, how can we strengthen training to ensure that high quality is maintained in all programs, both early diagnosis and screening. Private sector has a role here, of course, as well. And for us within WHO, we have also a very strong commitment to early diagnosis as a pillar of our cancer control response. So I'll stop there. Thank you again for the time and look forward to a discussion.
Thank you so much, Andre, for this very comprehensive and eye-opening presentation. We have received some questions in the chat, so I'm going to read you the first one that is from Sutapa Biswas, Cancer Foundation of India. How effective would ultrasonography be as opposed to mammography for premenopausal women in LMICs like India?
So I think Ben will touch a bit on this as well. So I'll pass it to him if he wants to make a comment in anticipation of his presentation or afterwards. Ben, do you want to comment now or in the presentation?
I could just briefly say that ultrasound and mammography are different tools for different applications, but the really key understanding is the distinction between screening, where as far as you know, there's nothing in the breast and you're screening the breast, versus diagnostic evaluation. Ultrasound is critical for diagnostic evaluation of palpable masses, but it's a pretty lousy tool for screening where you're just looking in the breast. And that's because the false positive rate is so high. We certainly can talk about this later, but that investigation is not panned out in terms of using it as a screening tool as opposed to working up palpable lumps that are clinically detected in early diagnosis.
Thank you very much for this answer. I can see that the messages are coming. So let me read the second question that comes from Ana Cabanes, Global Focus on Cancer. What would be the one message that the advocates should take to their policymakers about this?
Yeah, so thanks, Anna, and you of all people have done such a strong, had such a strong leadership role in defining these narratives. For us, the importance is for governments to put money in early diagnosis programs. What we have often found is that they do it ad hoc. So, okay, we'll do a little messaging in October for breast cancer, that's enough. But what we ask for are for very concrete actions that are funded by the government as part of a public health agenda. And the problem is, unfortunately, most governments don't allocate funds to cancer. So when we sit with them, we say, we will in fact estimate the budget for you. We will find partners that can cover some of the costs in kind, but this does require some government investment in this activity because outsourcing it entirely doesn't work. Of course, the awareness can be owned by civil society, and it should be because that's civil society's gift. But what happens at primary care absolutely needs a government investment. We've seen some interesting data from Rwanda about training medical students as an example. That's a small investment to ask governments. Let's work on training medical students in cancer awareness, breast cancer, and breast health. And in fact, we see the benefit of that downstream. So there are very concrete actions to go to the government and say, these are the 5 or 7 things that are relevant in your country that are feasible. Here's an estimated budget with them. And this is what we can contribute as the broader cancer community to support you in it. But this is what you're going to need, because without that skin in the game, unfortunately, it continues to be run by civil society. So it's about them also making some investments in those programs. The most likely investments that they can make often, again, relate to primary care training. There's also some countries that are willing to consider a patient navigator system, although frankly, those are still facility-based often and not through the Ministry of Health itself. And then often governments have, let's say, referral standards that they develop. This is something that we query governments about, but frankly, and my own concern and reflection is that those referral criteria are just left to the side. So yes, it's good. Government should invest in it. It is part of our checklist of do you have this? But we do struggle with implementing those referral criteria. How we can do it better, yeah, I think that's an important point for discussion. And sorry, the one last thing that they can also do as it pertains to referral that we've seen some success with is to define diagnostic pathways. So we're starting to see the emergence of cancer diagnostic centers. So in a country like Sudan, they were thinking, okay, we don't want every woman who has a breast lump to have to come all the way to Khartoum, which is the case, because that's where the only pathologist who had been functioning. There was one, I think, in Darfur. So they started saying, well, maybe we can put 4 diagnostic centers around the country, and those will be one-stop shop for high-risk cancer symptoms. So we don't take every woman who has a breast mass and ask them to go, because that's where they see a lot of drop-off. And the other thing that was happening is when the women wouldn't travel, they would go in for a surgical procedure and come out with a mastectomy for a benign lesion. So we were trying to find ways in which we could build up capacity in those diagnostic centers for things like corneal biopsy, working on the specimen transport network and seeing if we can get it to the capital while we build up the pathology, or look at telepathology, but it wasn't so feasible in the country at the time. So that concept of diagnostic centers, it's emerging. I don't have great data behind it other than what we've heard from a few countries, but it is something that may have good validity in the long term.
Thank you very much. Andre, I know you have to leave quickly, so I will just open one more question. I see there are much more, and we'll take the time after Ben's presentation to get back to you. So the last question for you, Andre, is from Rania Azmi. She's asking, I have a question for the step prior to early detection, which is prevention, recognizing that it could be even more difficult than early detection, the way you are describing. So is there any integration of efforts between what's done in early detection and prevention?
Yeah, my goodness, what a great question. This is also something we could spend another full session on. So prevention as a primary focus for cancer prevention and control in the agenda is, of course, the highest priority in many regards. But in breast cancer, we also have to be cognizant of both its time horizon and the likelihood that it will succeed. So cancer prevention broadly, most of the highest impact interventions are those that are policy related. On that side, the need for integration isn't that high. For example, tobacco taxation, plain packaging, there isn't necessarily a need to integrate with other early detection programs. Where it is absolutely relevant, as you rightly point out, is at the primary care interface, because that's where we see prevention and early detection merging. That's the most likely site in which you can have health services oriented around both functions and decentralized close to the patient's home. Now that is a little difficult because we do want to create mechanisms in which we're not coming with totally siloed prevention messaging, but do it in a more comprehensive way. So looking at health literacy as another important mechanism and primary care capacity. So one thing, again, going back to training of primary care providers, of clinical officers, et cetera, what we often do is say, what is your full curriculum? And look at, do we have the high impact prevention interventions at the clinical interface, and the same thing for early detection, because that's how far back we have to go. The challenge with trying to get to every primary care provider in the country is that integration is very difficult. You can do it in a few sub-regions, but to do it nationally, the most important entry point is going back, in fact, to medical training and focusing on good quality nursing education, good quality physician education, and also looking at a cadre of community health workers that go door to door, but we're not paying them just to do cancer messaging. They should go door to door for general health literacy. And that's where we see integration. So integration, not just within the cancer agenda, but more broadly, so that we don't lose efficiency gains that can happen with comprehensive literacy programs and with health outreach. But it's a very good question, a very challenging one.
Thank you so much, Andre, for this presentation and all your amazing answers in such a small amount of time. A big thank you, and we let you go.
Yeah, thank you. I'm so sorry I have to depart early for another meeting, but it really is a privilege. And my thanks also to Ben for inviting me to partake in this. He can answer everything and more. So see you all shortly, and wonderful to be in touch. Thank you again.
Thank you. Bye-bye.
Bye.
So this being said, let's move to your presentation, Ben, and to the participants. As I said, if you have other questions during Ben's presentation, please don't hesitate to use them in the chat, and we'll get back to the questions that have not yet been answered.
Thank you very much, Sabrina. I want to just touch on that last question, the prevention question specific to breast cancer. And because that it's, for a long time, people argued that, well, let's just do prevention and not worry so much about the early detection and treatment and the other areas. If you look at the risk factors for breast cancer, risk factors that we know about, such as delayed childbirth, menopausal, late menopause, exposure to hormones, the Gale model risk factors. If you looked at all of those risk factors, they explain maybe 30%, maybe 20% of the breast cancers that we identify. So even if you focused on an exclusive prevention strategy for breast cancer, and you actually could get everybody to do it, like lose weight, be physically active, all these other things that were good for other diseases, you still would leave the majority of breast cancers unaddressed. But actually, some of the risk factors for breast cancers are not things that you want to fix. So that, for example, educating women delays childbirth. Delayed childbirth is associated with higher breast cancer rates, but having women get pregnant in their teens is not a good social solution for obvious reasons to address this. And that's why we have to move into this focus of going beyond prevention strategies, not to ignore them, but to recognize that they have limited applicability. So what I'm going to do in this presentation is go beyond what Andre just did through that excellent presentation. And I'm going to talk about more specific focus on breast cancer and early diagnosis. The Breast Health Global Initiative was co-founded by the Fred Hutchinson Cancer Research Center and Susan G. Komen for the Cure. I have no financial disclosures relevant to today's talk. I'd like to look first at the Global Cancer Challenge as related to breast cancer, because the numbers are really quite stunning. Breast cancer is the most common cancer among women around the world. It has the greatest prevalence, and it is the leading cause of cancer-related deaths. If we look at disability-adjusted life years that are lost, more are lost to breast cancer than any other cancer. So it's problematic and becoming worse. It used to be said, oh gosh, breast cancer is really just a problem in high-income countries, and that's because the incidence was higher due to screening and early detection efforts. But actually, the shift is now towards low and middle-income countries. Today, the majority of breast cancer cases and deaths occur in low and middle-income countries, and by 2030, it will be 3/4 of the 2.2 million cases and over 800,000 deaths that are projected to occur. All 75% will be in low and middle income countries. There's this very broad array of outcomes. So in high income countries, 5-year survival is greater than 90%, but it's 66% in India, 40% in South Africa. And so while those statistics are certainly grim, it also demonstrates potential. That if there's this big range, that means there's something we ought to be able to do about it if we could just sort out how to translate what is done in high income countries to low and middle income countries in ways that are practical, realistic, and sustainable. If we actually look at sub-Saharan Africa, this is new data coming out of IARC that's in press, and it's looking at the number of orphans that are produced by breast cancer. In sub-Saharan Africa, half of the breast cancer deaths occur in women under the age of 50. And for every 100 of those deaths, there are 210 children who become maternal orphans. So this has a generational impact. It's not just the present time, it's future generations. These are reasons that we need to be thinking this through now. Now, looking at the incidence of breast cancer globally, the darker colors indicate higher incidence. We're looking at all ages, and it's the high income countries where we see this greatest incidence. On the other hand, if we look at mortality, it's a reverse, where the mortality rates are highest in the low and middle income countries. So there's this relationship where clearly when we have too little detection, mortality rates become exorbitant. And recognize these are age adjusted. So these are corrected for age distribution. The prevalence of breast cancer is highest in high income countries, and that's actually because we do pretty well with breast cancer. Women live for a period of time, even with metastatic disease, when treatment is available. But as commonly said, as Andre referred to earlier, that, oh, well, you know, breast cancer is really just much more common in the younger age groups in low and middle income countries. Actually, if we look at the distribution of breast cancer under the age of 40, the prevalence is highest in these same high income countries. So it really is the same problem for young women with cancer, whether you're in a high income country or a low and middle income country. It's just that we have more cancers in older age groups when we screen. So that this young age issue is global. This is data from IHME, and what we're looking at here is change. This is how is breast cancer incidence changing over time. And so the darker colors indicate more rapid rises. So you can see that the problem in incidence is increasing at much higher rates in the low and middle income countries. And similarly, we're seeing this acceleration in mortality. Again, it speaks to why this is a very timely point to be addressing breast cancer at a global level. One of the theses of the Breast Health Global Initiative and WHO is that breast cancer is an important disease, not just for itself, but also as a model, as a catalyst for change. If we could address breast cancer effectively, there are many other cancers that can be addressed through similar mechanisms. So we want to avoid that siloed thinking of, I'm a breast cancer person, so that means I'm not an HIV person. Actually, we want to look at common infrastructure to identify what needs can be met that address all of these diseases, of which breast cancer is a sentinel process. So here we're looking at US incidence for breast cancer. Mammographic screening began in the early 80s and led to a rise in breast cancer. For comparison, we talk about PSA screening. And you can see that while PSA testing was started in the mid 80s, it led to this big peak in incidence of prostate cancer. But what did not happen was an improvement in survival. So screening does not work for every disease in every setting. There are selected circumstances where mortality improvements are possible. Breast cancer is one of these. We started screening in the early 80s. We started to see a drop in breast cancer mortality about 8 years later, and that drop has been approximately 2% per year since that time. There has been a drop of over 35% in breast cancer mortality since 1990 in high-income countries. So here we're looking at incidence on the left, mortality on the right in high-income countries for breast cancer. You can see that in the high-income countries, the incidence is high, but it correlates to that 2% drop per year that we have seen in breast cancer mortality in these same high-income countries. If we compare this with middle-income countries, the top curves are Switzerland for comparison. You can see incidence was lower, but that's on the left. On the right, the mortality curves are flat. So we have not yet seen that 1 to 2% improvement in overall survival on an annual basis. That's what we want to reproduce. Now, some have argued, well, gosh, if the incidence of breast cancer is lower in low and middle income countries, then maybe we just don't need to worry about it. That is a temporary phenomenon. What you're seeing here from the WHO report that Andre led, you can see that this rising incidence in incidence in Ethiopia will cross the lines that we see in Germany. Again, speaking to the point of we could address it now, we could address it later. It's better to address it now when the problem is less urgent. Now, from a system standpoint, what you're looking at here are the 3 phases of management of breast cancer. And this schematic, this patient pathway is the same whether the patient is in the US or in Kenya. It's because this is biologically based. It's not about the systems, it's about breast cancer. So the first phase is the patient interval where the patient presents to the system, whether it be through having a lump or screening. There's this diagnostic phase where you prove that it either is cancer or is benign. And this is really important and often overlooked because if we think about palpable lumps, 9 out of 10 palpable breast lumps are benign. So you have to have a system that weeds out the benign patients in an efficient way while proving who has cancer, ideally within a 2-month period. The reason we talk about 60 days or 2 months is that we have data showing that at 3 months, we start to see a decline in breast cancer mortality. So prolonged delays are highly undesirable. The third phase is treatment. We have to have treatment in place. As Andre was referring to earlier, it's actually not early detection that saves lives, it's early treatment that saves lives. This is different from cervical cancer where we really are fundamentally thinking of prevention strategies. But so for today's talk, we're thinking of this screening and early diagnosis topic and developing that in a practical way. When we look at high-income countries, some of the dialogue that we've been having is unhelpful in the low and middle income country setting. So the American Cancer Society revised mammographic guidelines to say, wait until age 45 to start, which from an evidence-based standpoint is quite realistic for mammographic screening. And then they suggest go to less frequent once we get to age 55. We should stop when the life expectancy is less than 10 years. This is all evidence-based and thinking fairly narrowly about screening as a test rather than population-based implementation. But then they say clinical breast exam is not recommended for breast cancer screening at any age group. Now, that's not because it's been shown that CBE doesn't work. It's because they didn't have evidence showing improvement in mortality, which is one of the endpoints, but not all of the endpoints. Those ACS recommendations are limited because they are assuming that everybody who has an indication for mammography is getting it every 1 to 2 years. So it doesn't apply when you don't have mammographic screening. It really does not address the point that clinical breast exam is a fundamental tool for evaluating breast lumps and breast cancer management. It's not sensible to say, let's stop doing clinical breast exams. And most importantly, those guidelines provide no recommendations for women under the age of 45. So if you're in a country where the fraction of women presenting at young age is high, then this really guideline doesn't help us. But we have to really look critically at the data. As you know, the mammographic screening trials, not all of them showed mortality benefit. The Canadian trials were an example that did not show mortality benefit and are often cited. So here we see through Tony Miller's work, 25-year follow-up for women that were randomized to receiving mammographic screening versus those that were not, and there was no difference in overall survival. This is different from the majority of mammographic screening trials. However, if you look at their data, what you'll see is that in the control arm, the women who were not randomized to mammography, the median tumor size was 2 centimeters. So actually, that's a very acceptable number. What this is saying is, whatever they were doing in Canada in the control arm, that's what we want to be translating to low and middle income countries. This clinical detection can downstage disease. How do we do this in practical ways? You also have heard that self-exam is discouraged. This is based upon the Shanghai trial that was run out of the Fred Hutchinson Cancer Research Center. And what they did was they trained women in self-exam in a cluster randomized fashion and saw no mortality benefit, but did see more negative biopsies. Now, the issue here was that actually when you look at the Chinese women, the women who were not trained in self-exam actually were pretty good at finding small lumps. 41% of the cancers that were diagnosed were less than 2 centimeters. So actually, the issue is not self-exam. The issue is training in self-exam, teaching specific methodology for self-examination, as opposed to finding the lump in the shower, that it didn't show a benefit to that. But it isn't that the women couldn't find the lumps, it was that it was probably not the right place to be doing the evaluation. Now, there are randomized trials for clinical exam in India, and there are two major trials that are ongoing. I'm going to show you one of them. These are women that were randomized to, in a cluster randomized fashion, either to no intervention or to clinical breast exam. And what they saw was they actually were successful in downstaging disease. So what you can see here on the top two graphs, this is overall breast cancer incidence and then incidence of early stage. Clinical breast exam successfully finds smaller cancers. That is actually the target. What they have not seen is a mortality benefit, which of course depends on treatment. So it's incorrect to say clinical breast exam that there's no evidence showing support for it. Actually, it is successful in downstaging and is part of the early detection strategies. So finally, what I'd like to talk about are obstacles to early diagnosis, because as we've been talking about throughout this seminar, the methodology for early diagnosis is really important. And as a reminder from the last talk, we have primary prevention, where we modify risk factors to avoid disease, unarguably desirable, but won't address the whole issue with breast cancer. Early detection is the broad section that we're looking at, where early diagnosis is finding the cancers that are clinically detectable but smaller, versus screening, where we're looking in asymptomatic women. As far as we know, they have no problem, but we're looking in that setting. The infrastructure for screening is vastly greater than that for early diagnosis. As we were looking at earlier, in addition to the fact that screening takes more resources and equipment, you have to screen a much larger group of patients to find breast cancers, whereas with early diagnosis, the group of women that you have to evaluate is much smaller. So if we screen 1,000 women with mammography, 100 to 150 will have abnormalities, of which perhaps 10 will be cancers. Well, we would rather look at the 100 to 150 through an early diagnosis strategy because it's more practical and affordable. The question is, can we achieve survival benefit with this in this setting? What I would argue is that question is important, but you have to remember, if you cannot successfully do early diagnosis, you cannot implement screening, because you have to be able to manage the palpable lumps before screening mammography works. Looking in asymptomatic women doesn't make sense if the symptomatic women go undiagnosed. Consider this example from Peru. Peru is a lower middle income country in Latin America. This was a study of women who were presenting with new breast cancers at a regional cancer center in the northern portion of Peru. Every woman over a 3-month period was interviewed. And the outcomes that they were looking at was delay, either greater than 90 days or less than 90 days, and stage of presentation, stages 0, 1, or 2 versus stages 3 or 4. A clear target is we want the majority of invasive cancers to be presenting as stage 1 or 2. And what you can see on this graph is the median delay from initial symptoms to initiation of treatment was over a year, 407 days. And it was both because the patient didn't present, but also because the health system delayed, and actually the contribution was greater on the health system side than the patient side. 93% of the patients self-detected their cancer. So this idea that self-detection doesn't work, actually, it's the major way in which these cancers were found. We spoke about the 407-day delay, but here's this really interesting finding. The women were asked, did you ever have a clinical breast exam in the past prior to this current event? So this is not a clinical breast exam finding the cancer. This was sometime in the past. When a woman had had a prior clinical breast exam, those women were more likely to come in sooner, to have decreased delay, and were more likely to have early stage disease. So you see, when we think in this very limited way about clinical breast exam as a detection tool, we forget about its other roles, such as an educational tool. By doing a clinical exam, we help women understand what it is that we're looking for, so that they then, when this comes up, they are more aware of when to come in. What that study showed was that this benefit of prior clinical breast exam actually was true at statistically, even when we controlled for household income and insurance source. So the use of clinical breast exams should not be discouraged. But we do need to have communication among our different groups. Those of us in the healthcare field actually do not make policy. It's the policymakers that make these decisions, and they are largely influenced by civil society. It's this triad that makes this work. We were asked by Susan G. Komen to do a situation analysis on behalf of the Ministry of Health in Tanzania. There were many findings in this report that were of benefit, but I just want to show you one of them. And that is, here is the pyramidal healthcare system of Tanzania. Women present in the primary healthcare clinics with a lump. It turns out that within their system, needle biopsy is not available until level 4. So the woman should, in order for this system to work, the woman has to be referred to the district hospital, then the regional hospital, then the zonal hospital before diagnosis can be made. Well, that's a clear flaw in the strategy, which they were not aware of because this is all new to the Ministry of Health. But you see that standard statement of, oh, well, you know, breast cancer is not so common in Africa, but it's really bad when you get it. That's not a genetic phenomenon. That's a health systems phenomenon, because only the most miserable women are going to make it all the way to level 4. And what it gets to is this core concept that there's some services we want to centralize for the purposes of improving quality. Some of our higher level treatments require that, but we have other services that we need to decentralize because that's how we improve access. So connecting the dots between the primary healthcare facilities and the hospitals where diagnoses can be made is a fundamental need. So this diagram, what we're seeing here is what we need to implement at a global level. And the question for WHO and other groups is, how can we do this effectively to create that 1 to 2% drop in annual mortality that is translated to a 35% improvement in breast cancer survival at a regional level. But we also have to recognize that while we talk about the health system side, there is a community side. We produce survivors when our treatments are effective. It is these survivors that tend to organize into advocacy groups. It is these groups that create awareness. So we must partner with civil society to make these techniques effective. Just because we build it does not mean they will come. In summary then, mammographic screening is unaffordable in most countries, and it does not apply to women in the youngest age groups, which is a focal area of concern. Early diagnosis through clinical detection is practical, affordable, and it's a necessary prerequisite to screening, so that it's not optional to be doing early diagnosis. Using situation analysis, this is important to determine where practical obstacles to timely detection and diagnosis exist, because what we want to do is build systems on top of what we have rather than focusing on a hypothetical situation. Ultimately, improving breast cancer outcomes requires a systematic approach that addresses the entire healthcare system. This is an opportunity for us, because if we can do breast cancer well, there are many cancers that we can address. Colorectal cancer is not far behind, and think of other non-communicable diseases that also need this shared infrastructure that promotes longitudinal care over time. Thank you very much for your attention.
Thank you, Ben, for your presentation and all these insights with that example. It was so clear and interesting. So well done. Questions reigned in the chat, but we have 3 minutes. So I'm going to try to consolidate them. And there are many questions around tools used for early detection and screening. So I'm going to put them all together. Nita from Indonesia is talking about DNA test or genetic testing and wondering whether it's medically recommended. Is the result valid and accurate, and could it replace a PET scan? Dr. Ashara is asking, what do you think about thermography? And Peter Vuileske from Botswana asking if you've seen successful implementations of clinical breast exam as a tool for early diagnosis. I know you cannot answer everything developed, but
so let me take a shot at that. It's interesting that in healthcare, we tend to think of technology as being the solution when we forget about human resources. Actually, for clinicians, the old-fashioned taking a history and doing a physical exam is a powerful tool that in the high-income countries, we're actually losing our skills. So in terms of DNA testing, there's a lot of evaluation going on with this. It's very interesting, but understand that that actually is going beyond mammographic screening. That's actually even more complicated than doing mammographic screening, because if your test is positive, you still have to do the same diagnostic workup to find out what was making the test positive. So there may be a future in this. There's interesting work going on with that, but no, we do not have data that it would support this. And from a system standpoint, it would most certainly not be the next step. Thermography, what you're doing with thermography is you're looking for masses that have higher blood flow. It makes them hotter. This is not a new strategy. This has been used for a long time. And to oversimplify it, what thermography tends to find are the cancers that you can already see from across the room, because that it's not particularly good for the small cancers, the early disease. And so we have not yet seen that thermography plays a major role over the standard tools that we're using. We commonly talk about replacing tests. And I would say that rather than, well, let's replace the test, no, actually, let's figure out how to make the system work to utilize the tools that we have. What is very clear from our breast cancer data is that we can, using the standard tools that we already know work, that's the next step, as opposed to finding the magic bullet to figure it out down the road. I'm not opposed to magic bullets. It's just not the big solution. And then the final question had to do with clinical breast exam. The way I would pose the question is, you want to look first at the population. If the majority of women are presenting with stage 3 or stage 4 disease, that is a role where clinical detection, of which clinical breast exam is one component, is clearly important and effective. If the majority of women are presenting with small cancers, then that's where the imaging detection starts to come in. But we really do need to think about clinical breast assessment. That means taking a history and doing a physical, using selected imaging studies to evaluate, and then doing tissue sampling to sort out what's benign and what's malignant. That clinical breast assessment is a real need globally and something that we're looking at developing over time.
Thank you so much, Ben. I even have 1 more minute to conclude. So I will just end up by reading what Dr. Ashera has written in the chat. Your presentation was very thought-provocative and formative. And I think on behalf of UICC, but also all the participants here, we want to warmly thank you for sharing your time and expertise with us. So,
thank you very much. On behalf of Dr. Abawe and myself, we're really pleased to be able to make this presentation. We need to talk about this more. So thanks so much.
Thank you. So you are all invited to follow the next virtual dialogues of UICC. The next one will have a topic that is directly connected to this one: reimagining cancer screening and diagnosis in the COVID-19 area, in which we are unfortunately are at the moment. So this will be taking place the 3rd of November and is part of the new series that we're launching around cancer beyond COVID-19. So see you there and take care. Bye-bye.